Yeah.
Hello, welcome everyone. Great to have you in this new edition of the Deep Dive series, where we invite foremost UX Design Awards winners to share approaches, insights, work success stories in the UX domain. I'm Julia Oñate. I'm the project manager of the UX Design Awards, and now I'm gonna hand it over to my colleague.
Yeah, I'm Luca. I'm responsible for communications at IDZ and a helping hand for Julia and Annke at the UX Design Awards. And yes, today we are very excited to present a Gold Award winner project from the UX Design Awards in 2025, which is called CIARTIC Move, designed by Siemens Healthineers Corporation, which is located in southern Germany in Bavaria. And it's a device that assists surgeons in the operating room and helps them take X-rays during operations. And when the jury came together in 2025, talking about the projects, this jury was really impressed by this product and its simplification and automation in the processes in the operation rooms, reducing work steps and optimizing work process overall. And also the holistic design approach through its intuitive color-coded design, which just supports really clear communication within the medical team. And also in the research process which you will hear today about, also the extensive user testing in realistic settings, and of course the necessary professional medical feedback on it. And in the end, it's always about the relevance, and the relevance and impact of this product was huge and is huge. You will hear about that, setting a new standard for precision and efficiency in surgical environments. Yes, so
yeah, that said, today we have two core members of the team with us, Annke Osthues, which is the UX designer and project lead at Siemens Healthineers, and Malte Reinhard, who is the UX designer. They both will tell us the story behind the product and provide insights into the research and design. And if you have any questions, please send them via our LinkedIn chat, and we'll pass them to our speakers. We're looking forward to hear about the story. So yeah, the screen is yours.
All right. Dear UX community, dear audience, welcome also from our side. Our topic today is smarter X-ray support, empowering surgeons in the operating room. Come join us for a first look. So this is the device where everything comes together, and we'd like to take you along on the journey, sharing many insights and details along the way. Welcome to the world of the operating room. Here you see the operating room as a working environment. That means there is limited space conditions, crowded environment, often many people, and high noise level. It's a strict sterile field. It's about sterile field requirements, and with the patient at the center, there is no room for error and only the highest level of responsibility.
Okay, and in the operating room, we have our star today, the mobile C-arm. It's a mobile X-ray device for intraoperative imaging. It helps to make real-time decisions at the patient table. As you saw in the image before, and on the left side, the OR is very crowded. So we have limited space, sterile constraints, and the mobile C-arm needs to fit in there. It must be maneuvered within this environment. Conventional C-arms, as you can see on the right, are quite heavy, up to 400 kilograms, bulky, and hard to move. They require manual positioning for every image. The technician, you can see it on him on the right behind with the tablet, brings and adjusts the system. The surgeon on the opposite side gives instructions and has no direct control over the X-ray device. So positioning and image parameters are controlled by the technician, and the surgeon looks at the monitors, which are quite small in conventional C-arms. The operation of the device is done with a tablet, which is for conventional C-arms quite outdated and cumbersome to use. This workflow is quite interrupting the flow of the surgery, as we have this dependency between the surgeon who wants to see an image and the technician who needs to deliver. Talking about the images, here you see typical images of mobile C-arms during different types of surgeries. For example, trauma surgeries with bones on the left in the middle image. Here you can see an implant fixing a bone in a foot, and in the middle you can see also a 3D scan that is being performed to ensure the positioning of screws. And on the right, a vascular surgery where you can see blood vessels being visualized. So it's all about these images. And today's setup is illustrated by this visualization. Here you can see the surgeon requesting an image. This is then being translated by the technician who brings the C-arm. They need to communicate back and forth, and the technician tries to understand what the surgeon actually wants to look at. They take several images that may not be the right ones, so they need to correct the position. And as you can see, this is very time-consuming and error-prone. So let's summarize the situation today. These systems are quite hard to move and heavy. The positioning requires a technician. The surgeons are not independent. And operating device is also done through quite outdated interfaces. Now, let's look at the initial idea behind CIARTIC Move, the mobile C-arm that we talk about today. Several years ago, the innovation team challenged the autonomy of surgeons. The idea is to motorize the system and to give the surgeon the power to control it from the sterile field. And in this video, you can see that with a use of joysticks mounted at the table, the surgeon can bring and take images with the C-arm directly without the need for additional technicians. And this was shown as first visualizations back in 2020. And that was our starting point where we knew this is a rough concept, but we need to translate this into a concrete product. But how do you develop a groundbreaking new system like that? So let's look at the Siemens Healthineers design process and structure. We follow the user-centered design process, as you pretty much, I assume you know. And we have a centralized design department with worldwide offices. We work in so-called crafts, multidisciplinary, and all projects is a true team effort. For example, we have a strategy craft, we have usability engineering, user research, interaction design, and of course also product design. And also this project is no exception. There are many contributors today that are not visible, but that also did an amazing job to bring this to life. Now, besides the process and the crafts that we have, we of course also have our design system that I would like to show you briefly. It's called SHUI, and it represents hardware aspects and also the digital aspects of our products. And here also we have a really engaged team of designers who are constantly improving and extending this design system. And of course, this was also applied to CIARTIC Move. For example, in the product design to match the hygienic standards, and in the interface design to match the environment of the surgery room and to make the X-ray images really stand out. Let's have a look at our process for this project.
Yes, thank you. Now I would like to share some insights how we work. In the process, we began with early co-creation sessions and conducted UX testing with surgeons and OR technicians in small groups. And the testing methodology was qualitative. On the image on the left side, you can see multiple 3D printed control handle variants. We see tablets, remote controls, and an Xbox controller. On the upper right side, you can see participants exploring all the different input devices, and we asked them to identify key pain points with workflow-based scenarios. On the lower right side, you can see a simplified operating room environment, providing participants with a familiar work setting. And early insights from this UX testing highlighted the need for autonomy of the surgeon and a mobile, simple input device. At a later stage of the project, we conducted several workshops. We used, for example, different methods, including focus groups and hands-on user evaluations. In the image at the upper right, you can see a focus group workshop during the final discussion round. In the image at the lower right, you see surgeons from different disciplines drawing their standard OR setup. On the images below, left and middle, you see qualitative testing of the chassis handle. You see qualitative testing of the flat detector buttons and handles. In the images on the upper row left, you see participants wearing blue lead vests. Those are required when they work with radiation to give shelter. And the test method in that case was using the participants' mental model. The so-called mental model consists of that we were creating the best possible setup of a test operating room. We made use of an anatomical phantom on the OR table covered with a sterile drape, seeming to be a patient. The C-arm was also covered with a sterile drape. Surgeons used gloves and lead vests, just that as they would do in real surgery. And additionally, we asked surgeons to work with radiation. So the goal was to simulate real OR conditions as closely as possible. And we were really successful doing this. Participants were eager to show us how they would work in the OR with different input devices. Of course, there were many challenges related to product design too, but in the end, the industrial designers did an excellent job. We even won the Red Dot Product Design Award in 2024 for CIARTIC Move, and the foundation for this success was the close collaboration between the mechanics team, the so-called, and the UX team, a partnership that has been well established at Siemens Healthineers for years. In the operation room, the devices used as shown here. On the left side, the main system, and on the right side, the trolley. The trolley primarily provides a computer and a large monitor, and the large monitor can be positioned so that the surgeon has a full view of the X-ray images. The computer supplies the device with the required power and processing performance.
Now let's have a glimpse into our interaction design process. And I'm sure you're familiar with these kinds of walls full of sticky notes. So, of course, we did a lot of extensive workflow mapping with Post-its, analyzing today's systems, but also rethinking the interfaces end to end, because we needed to develop totally new workflows, as this new C-arm was fully motorized, and we were redesigning and inventing new interfaces like the remote control, for example. We were also having new screen hardware, larger monitors with touch capabilities and a better touch screen. So we needed to understand the complex medical user needs, and this, of course, needs a lot of domain knowledge. And we at Siemens Healthineers, we try to get a lot of this domain knowledge to be able to understand the user needs by regularly going on sites. So to say, we go in hospitals and do hospitations, we shadow users to understand the workflow and the actual work they are doing to better design products that really match the needs and to understand the jobs to be done for these advanced procedures. So we developed a total new UX concept for this project where hardware and software come together. This is a UI prototype. You see one of many high fidelity prototypes we did for this project back in the time with Adobe XD. And during this time of, in a later stage of the interface development, it was actually during COVID. We did a lot of worldwide remote testing. So we were able to test various different prototypes with surgeons, but also other roles that are operating the device, like the technicians or even nurses, in a remote scenario worldwide. And of course, many iterations, many back and forth, many tests, many alignments with development, then led to the final product. And let's look into some of the hands-on testing maybe.
The next phase was about formative user evaluations. There we specifically tested risk-related topics, and they were embedded in familiar workflows for the surgeons. First and foremost, breaking the device and avoiding collision. Key learning for participants were, as soon as they would press go on the remote control, they are responsible for ensuring a clear path with no obstacles when moving the C-arm. The same applies when using the chassis handle. At the same time, we gained a deep understanding of the new way of working with an automated driving C-arm. Surgeons in particular told us that they greatly appreciate the ability to operate directly from the sterile field. If necessary, they can even work without the support of an OR technician, for example, during night shifts or if no staff is available. And the keyword here is staff shortage. The feedback from them was really great because right away it was like, yes, this is a concept which is going into the right direction. The images show the following. We were testing driving tasks, means operating the system one-handed and two-handed from the chassis for driving. We tested braking the device, testing different braking methods. For example, the e-stop, or let go of the chassis handle, or let go of the go button at the remote control. Using wired and wireless hand controls for steering the system. For example, images on the lower left side or on the very right side, both show surgeons operating from within the sterile field. And the images upper row left and middle show OR technicians using the chassis handle or the wired hand control. We were also asking for storing and recalling system positions. This is one of the key features of the device. And there was, again, a lot of positive feedback from all surgeons. They were instantly recognizing that storing positions means saving time, because once they are stored and can be recalled several times, which was great. So the feedback was really, really nice. Testing standard clinical workflows using the UI on both the monitor and the tablet, including all HMI input locations, both digital and physical HMIs, was a great challenge and a great success at the same time. Here you can see one of the results, the so-called formative evaluation report as one example. This document is just one of many regulatory deliverables we created. It compiles all relevant and required user evaluations conducted before the final step, the so-called summative test. In this summative test, the usability of a medical device must be demonstrated with at least 15 US participants per clinical user group. And successfully passing the summative evaluation is a mandatory prerequisite for market approval by the US FDA process. Here you see a holistic HMI concept which was developed for steering the device. It's ensuring seamless device operation on both sides of the operating table. On one side is the surgeon's workspace. You see on the left side images at the bottom. There's the remote control, hold from 2 gloved hands. And there's a flat detector on the very low left side with handles and buttons. The OR technician's workspace is seen on the right side with the wired hand control or the chassis handle and the chassis panel. It's both consistent. There's both everywhere consistent use of icons and colors. This was strongly requested by surgeons themselves during early user evaluations because a consistent color concept and consistent icons, it enables clear communication between surgeon and OR technician and provides that way optimal orientation in the operation room. Hand controls on both sides of the OR table look almost identical, another plus for easy communication. Also requested was a meaningful redundancy of input location, means the surgeons and the OR tech always have the choice. Do they use the wired or wireless hand control or the chassis handle or the panel on the FD? As we talked about breaking the device and avoiding collisions, the image shows silicone patches or strips on the C-arm highlighted in light blue. And if the device contacts anything uses these silicone areas, it stops immediately. And the user must steer the device out of the collision. The LiDAR sensor, shown in yellow, similar to those used in cars, prevents accidents with people crossing the device's path. It enables users to drive at a higher speed when moving the device to an operating room or back to its parking position in the hallway. And the LiDAR sensor ensures that the device performs sudden braking maneuvers if needed. Finally, we would like to share a video with you that shows how the C-arm is used in today's operating room. And what we are particularly proud of is that the remote control made it onto the instrument table. And you see here how it's getting draped. This is the remote control, the wireless, and it's handed over from the nurse to the surgeon right now. The surgeon is taking it as any other instrument. And now he's taking the C-arm onto the OR table over the leg of the patient. And now he's positioning the C-arm at the right position and saving the position with a press of a button, storing this position. And after doing so, he's handing it over back to the nurse. The nurse is then releasing X-ray with a smart control. This could be done by the surgeon as well, but he's working on the leg itself. So he's handing it over to the nurse. Now he's back to the instrument, to the smart control, and reaching out to start for the next position, the lateral view. And this is going on for a while. And then storing position is the feature which is the one to be done during surgery. And the remote control truly become an instrument for the sterile field, and it earned its place there. This is something we really were proud of, because we were for a very long time not sure whether it would make it to the instrument table. To conclude, we would like to give you the final word to our users.
Unter Verwendung des vollautomatisierten
The fully automated CIARTIC Move C-arm allows me as a surgeon to save my C-arm positions before the procedure begins. Saving positions means I can move the C-arm to precisely those positions myself during surgery.
Previously, you had a process of trial and error to even find the right position. This is no longer the case. And of course, that means a reduction in total dose or radiation dose.
We've already found that we save a lot of time because the system can move into and out of position automatically.
We're also facing a shortage of staff in the operating room, as is the case in so many hospitals around the world.
In other words, changes of personnel in the operating room, interactions between operator and assistant. Which way is up and which way is down? Is up toward the head or toward the ceiling? It's simple things like that that often lead to misunderstandings in everyday practice and also result in delays and increased radiation exposure.
The advantages of smart control for me as a surgeon are that I can control the instrument from within the sterile field and have a precise idea of what it needs to do, where it should go, what angle it should adopt, and I can do all of that myself, which obviously saves time.
And this concludes our presentation. Thank you very much for listening, and we are happy to ask some questions now. To answer some questions.
Thank you. Thank you very much. It was very interesting, and obviously it's a very complex project. So we're really happy that we could hear about it from you. So yeah, in the meanwhile, I just want to remind you, if anyone has questions, please, you can just send us on the comments on LinkedIn, and we're going to pass it over to speakers. But yeah, on the meanwhile, I would like to ask you something, and it was like, if you have any highlight, like if you had any situation that was difficult working with surgeons, or if you had like any feedback directly from surgeons that you said, okay, this is going to help me afterwards to improve the product, or yeah, something in this line.
I think we have done a lot of workshops with US surgeons and with Europeans as well. And what was a great pleasure is that surgeons are really persons who know what they want. So if you ask them, what do you want? You get more answers than you ever expected. This is one thing. And the other thing is that you then have to interpret, how do we translate it to a product? Because they even tell you, do it like this, do it like this. I want this. I want to see this here and this there, and do it like that. And in the end, when we have these user evaluations done, we sat back together and said, what did they say? What do they mean? What do they want? And what Malte said before is really good. You have to gain deep understanding of the clinical domain before you only start into user evaluations. Because if you don't know the domain knowledge and what the surgeon is doing, then you don't know what you see, because what you see is just part of the iceberg, which is huge. And you have to know since years, if possible, what they want, where they are, and what they need for the next step.
One thing that I just think of right now is, we showed some Xbox controller in some of the screens that we put on the table to find out what kind of input device they like. And me, as I was still very young at that point, I was curious what surgeons, also some older people, how they would react to something like that. But I can see a paradigm shift, that people are actually taking over things they know from other products, consumer products, like an Xbox, where they know how it's used to steer other stuff, but it's familiar. So we can translate what works well from an Xbox controller to a medical device. And that was quite enlightening for me.
So I think it's really, Annke, like you said, it's really important for a new UX designer or product designer coming to a field of medical, in the field of medical, to like dive deep into like the real needs of surgeons. And we watched the video, and I listened, or I heard like the time aspect is like maybe one of the most important thing in a hospital. Everything is in a hurry. People come in and go out like the whole day, and every minute of time saving maybe is like really important for a hospital. I don't know. It's something that I experience now. What do you think about it? Or is it maybe also like the seamlessness of the tools?
Yeah, definitely. I mean, OR time is really, really expensive, as most of you maybe know. And yes, if you save time and especially also mental capacity, because what Malte also mentioned before, if you have the regular conventional C-arm, the surgeon has to talk to an OR technician and explain, please go up higher, please go left, go headwards, go footwards, please do an angle like this and that. He has to explain some instrument, what he's not interested in because he wants to do surgery. It's just a helper in the room, the C-arm. But now we gave him an instrument to put these angles and all this, the whole setup by himself and position the C-arm as he needs it, for example, for a hip surgery. Hip is a kind of difficult anatomy, so they know this needs an angle like that and exactly knows where to position the C-arm, does an image, okay, perfect, I can do it, storing position, taking the system back to the wall, and for the next shot, X-ray image, he can, by himself, bring the system to the OR table back and back to the wall. So no more waiting, because waiting is for them kind of a torture.
Mhm.
They really hate waiting, and they say, where is my nurse? Where is my OR technician? Because they run away, do other things, and then they have to wait during surgery. This is really a torture. And now they can do it better by themselves. If there's staff shortage or at night shift, nobody there, they can do it by themselves. They can take the system, coming to the OR table, making the correct positions, and then starting surgery. So it's perfect. And this is the feedback we got. And this is the paradigm shift Malte was talking about earlier.
Yeah, I can also imagine, like, being a surgeon, it's really important to stay focused and like stay in your focus and work kind of, yeah, focus mindset, and you don't want to get distracted, and as much distraction you cut from like making like this kind of tools more intuitive and more seamless, the better also the surgeons can like stay focused and be maybe a better surgeon also. That's just my guess, but maybe it can fit.
Yeah.
We have a couple of questions from the audience, or do you have another question?
Yeah, but I can ask it later. So we
No,
can
you
go.
can ask now, and I'm gonna.
Okay.
Yeah.
So I was also curious that I want to ask something more about the internal process. And yeah, I was curious about how this, like a type of product like this, how does it, like, how is the, how this device can get approved in the medical sector?
Yeah, I will start, and then maybe Annke can take over, since she has a lot of experience in this kind of approval. But of course, it's not a consumer product that you can just launch. As Annke mentioned, there are some regulatory hurdles that we need to take in order to sell the system in different markets. And we have to prove that, for example, we need to work together with risk engineers who identify potential risks. Like, for example, this is a system which moves sometimes on its own only because of pressing a button. What if someone falls into it? And that's why these silicone patches, for example, needed to get developed. And we needed to also, from a UX standpoint, develop concepts, how a user reacts if a collision appears, what's the message on the display, and how do you solve that. And of course, all these things have to be documented to prove we identified a risk, we have a mitigation, we tested it with users worldwide, and it actually passed the test to be safe. And then, so to say, in a short version, you can release a product. But this is extensive and it lasts very long, and it's also quite dry if you're only into being fully creative and doing kind of nice design. then this process is more dry, but it's necessary, especially in the regulatory environment of medical devices. What do you want to add?
It's exactly like this, and maybe a small story as another aspect. When we were developing this braking and collision concept and risk was involved, we were all thinking about how can we best do this education also for the users. First thing is that we always have 2 points, two authenticators. Like you choose the direction where you want to drive, and only then you press a button to release the automated driving. So it's always a 2-step factor. And then the story behind it is that we said, okay, we have to have a new education training where we have hands-on education for our users, because we train all these new devices in clinics. And the training was changed because we recommended to do more hands-on training so that they really understand. I, as a user, if I have to release driving, I really have to look on the path. Is it free? Because in the operating room, there's always a lot of devices standing around, and after 5 minutes, the path is not free anymore. So I have to get used to that. I, as a user, if I release the driving, that I know the path is clear, I can really go. And then only then I can start the go button, or I can start to drive the chassis, or I can move the system in any ways.
Okay, thank you.
Yeah, I have luckily 2 questions from the audience with like same kind of direction. One from Audrey from Quebec, and one from Sebastian from Munich, regarding your design process and designing in medical environments. You mentioned that you had to review workflows and introduce new ways of working. But from the perspective of Audrey, it seems that medical environments are more strict, and maybe it's hard to renew workflows and way of workings. And how did you manage to do this? Like, is it really that hard, or is it just a cliche? And Sebastian asks, what would you do differently today? Maybe also in this way of working or in this process. Yeah.
So first question. So yes, the hospital and especially the surgery or operating room is a very strict environment with clear responsibilities, hierarchies, and established workflows. But it's obvious worldwide that staff shortage is a problem, and that it's very hard to find good staff that's actually willing to work in night shifts and so on, to get the job done. So there is definitely a need to have more automation in the operating room. And I think what really helped in the beginning was to create or recreate real environments for this mental model, operating rooms, and put the surgeons there and let them play with the new device, so that we can see, are they actually like accepting this or not. But I think all the surgeons immediately got the benefit that this autonomy gives them, that they don't need to be dependent on another person to do what they want to do, but they can just do it by themselves. And surgeons are also humans who sometimes like to play. So driving this arm, moving it in all directions is for some of them fun, and they are proud of doing it. So it was actually not a struggle, because it's also some kind of joy of use, I would say, because it's moving really intuitively if you figured out how it works. And of course, this took a while. And then we were happy, and of course we didn't know is it really accepted then in the real world, or only with our test participants because we paid them? But as we know from also site visits recently, the hand control is really used, as you could see in the video, but of course this was also a video. But really, we visited several hospitals and watched them using the device as we imagined. And of course, this is a nice confirmation of the work we put in, that people are actually using it in a way that we imagined it, how it could be.
Yeah,
Now,
it's a bit of a paradigm shift, because I know a little story, like Malte was telling the story, it was really great. There's another story where people said, in the beginning, they were complaining, if I press the go button, it takes 8 seconds until the C-arm is finally reaching the OR table. And this was told by a surgeon. And after a while, he realized by himself, but listen, you know what? And the fact is that it's really nice to have this kind of mental pause where everybody is concentrating on the next step for 8 seconds. And then it's much more silent in the OR, much more relaxed than pushing a 400-kilo C-arm onto the table, taking it back with a lot of forces. So this is something, I like the story, where he realized all of a sudden that this is a paradigm shift. And in that way, he realized, okay, this is it, where we want to go in the next years with automated driving.
mm-hmm.
Yeah, you clearly have the arguments on your side. But another 2 questions were about the availability of surgeons participating in your workshops and tests. So is there, like, how did you manage to get this people who have like a full schedule participating in your tests?
Like, did you, how does it work exactly? Like, do you?
They want to come. They want to come. They want to give their knowledge, because nobody ever is listening to it then, because they kind of in a closed, hidden community, and they're really eager to show you, this is how I want to do it, and please do it like that, like this. And even if they're all day, it's like their days are packed, they come. And if we ask them, could you come again? Sure, anytime. Let me know on Fridays, on weekends, and that way. So we did it sometimes also late at night, early in the morning, or on weekends. So this is how we work sometimes.
And also for some of the tests, we also came to them. So we also, with prototypes, we went into the clinic. We spent the whole day in the operating room or between operating rooms in sterile clothes with an iPad with our prototype. And every time someone seemed to have some spare time, we asked them, hey, are you open for a little test? So that's also another option. And actually now, we also, as we are a big design team in our company, we have a dedicated team who is doing all the contracting with clinical users for the designers. Because in various projects we always need user feedback and site visits and so on. So we have dedicated contracts only for this with medical stuff from all around the world that we can contact and regularly use for our development and design feedback loops. And this is really great and much needed in order to really follow the user-centered design process.
For me, it's also really interesting. If you talked about including them into feedback regularly, but are they also like in the ideation processes, like in the very beginning, which next product do we need? Do you have like a regular monthly meeting with a couple of surgeons where you like exchange ideas and problems, and out of this you go into ideation, or are they
In the regular process, yes, but back at that time, the mobile C-arm business line was just growing, and we needed certain steps. And only when the next steps of where we want to go, where we can go, were ready, developed, then only we asked surgeons to participate. And once we, for example, in 2018, we did a big workshop, 3-day workshop with US surgeons, vascular surgeons and trauma surgeons, and they really liked it. They said it was a great pleasure to be there, and they had a lot of fun, and we were pushing them to all these kind of user evaluations, and they loved it because they say, I wasn't boring for a minute. We really enjoyed it. We read the operator manual this night because we couldn't sleep anyway. And for the next day, we were like, can you do this and that again? And this is how workshops were running. And I'm especially convinced of this group of people who are really eager to work together with you, to help you with research. And this is key of our all-day work, I would say.
I also want to ask something related to the feedback. And I was curious if you remember what was like the user feedback after the first real usage. So what did you hear? What was the feedback like the first time? I guess it's some time ago, so I don't know. If you
it's some time ago, and of course we tested different aspects. Of course, there are so many features of this product we don't test all at once. But for example, early on, I remember there's a handle at the system with sensors in it that help you to control the device to drive it like a shopping cart. As I said, these systems weigh up to 400 kilo. So if you don't have motors, it's very heavy to use. But steering them with this shopping cart grip and with the sensors needed some calibration, because you would also be confused if you push it only a little bit and it starts driving quite fast, because this is a heavy machine. You would be maybe scared. So I know in the beginning it was quite funny to drive back and forth in the factory actually to test the right amount of speed and force and feedback to figure out the right driving calibration for these sensors. And this needs a lot of iteration, because it's a lot of fine-tuning to make these things work smoothly and intuitively.
Thank you.
Really nice insights. And yeah, we wanted to talk about also a bit about your positions and roles in this project, maybe also your careers.
Your background.
Your background. So we know, Annke, you're the project lead. And Malte, you're an UX designer. How big is your team, and how many like departments were in the core team of this project? And and your roles within the team.
And how do you also like arrive to these roles?
Yeah.
Do you want to start?
Okay. Yeah. All right. So back in this setup, we had, of course, a multidisciplinary team. I was mainly doing the interaction design. We also had another interaction designer for support. We had usability engineering and research, and of course also product design support. But of course, some domains maybe come in and out and are not needed all the time, but the core team is maybe 4 persons, I would say. And as this development takes a long time, you need to be quite patient. For us now, this is also a few years back, and when we started with this project. And to your question about career, so I ended up, after my bachelor in product design, starting at Siemens Healthineers, always with the wish to gain more knowledge, or to actually become more an interaction designer, because this was more of interest. But luckily, my product design background also helped me to design in this project the workflows and also these hardware aspects to understand the interplay between hard and software HMIs better. So I was starting as an interaction designer, and then during the first years of working for Siemens Healthineers, I also figured out I'd like to do a master in interaction design, but I don't want to get back to school without earning any money. I was getting used to the comfort of having a job. So I decided to study part-time and reduce the working hours and doing the master's part-time. And then I did that, more focusing on interaction design in Austria, then coming back full-time again and working for several different projects in different domains. What about you?
Yeah, I think it's a great career path which Malte did, because there come together a lot of factors. He's a product designer, he's an interaction designer, and he gained deep knowledge of the clinical domain. So this is perfect. And I think based on that, we had another colleague with great capabilities. He's also a product designer and interaction design. He just dived in. Matthias, hello, if you look at us. So this was a very small team in the very beginning, and some other researchers, product designers were there as well. And that way that we all had gained deep clinical knowledge is part of the process. But let us forget that there is an R&D department doing the development, and we had a great partner there from the innovation team. So it's Alex Gemmel, physicist. He was bringing this project in as his doctor's thesis. So he was bringing in this kind of automated driving system, and it was developed at Siemens Healthineers, and he was in many times going this extra mile, which is necessary to bring a real new device into life. And I think we all contributed a lot of Herzblut to really get this going, because I remember at least 100 times where we had difficulties. How to integrate the emergency stops in a hand control. No, we don't want to have such a big e-stop. This would not be possible from a usability standpoint. Or do we really need 6, 8, 10 emergency stops all around the device to get it stopped everywhere if braking is necessary? We had all of these funny discussions and interesting back and forth movements, but of course it's related to the typical R&D process and the typical R&D development process. So we were part of the R&D development process, and it's related to the milestones of the development of the project. In that way, we were just arranging ourselves into this landscape, and maybe my role was to little bit fly over it and see, okay, where are we? Implementation phase. Okay, wait, this is not how we wanted to have it implemented. Let's look for another solution because it's not feasible. So you have to find the right spots in time. So to not destroy anything, but to make it feasible, to also look at the risk issues, to get it solved and make compromises as well.
Yeah, quite a challenge, I can imagine. Thank you very much.
We have one last question actually that I would like to ask you, and it's related about the project duration and like the amount of hours that it takes to produce this project, like to work on the project.
Yeah, maybe did you work like full time since I don't know how many years on this project, or do you work on like 4 projects simultaneously?
Yeah.
Okay.
Process with the whole R&D team. So we're not working just for one project, but simultaneously for 3 big ones, 2 big ones, 4 small ones, like it's needed.
But comparably, this was, I would say, quite a big project. So for quite some time, it was the main project for most of us, as it incorporates really not just an evolution of an existing product, but really thinking beyond what we have today. So it's not just redesigning and reskinning, but taking many years actually. Yeah.
Yeah, so you can be really proud. And I think you have the next projects in pipeline, I can imagine.
Yeah, and I think that with this we should be ending the deep dive. But first, we wanted to thank you a lot, Annke and Malte. It was very, very interesting. And again, congrats for winning the World Award in 2025.
Thank you, and thank you to the team. It's not only us, it's the team. And thank you all.
And thank you for moderation. It's really nice.
We just want to send a reminder to everyone who's watching. Next week, no, the after, like the 4th of March, is going to be the winner announcement for the UX Design Awards Spring 2026. It's going to be live as well on LinkedIn. And yeah, if you follow us, you will see on social media. And also, like, if you are in our newsletter, you're also going to get the information. I don't know if you want to say something else.
I'm going to post a link to the, I'm going to post a couple of links in the chat that you stay updated. And again, thank you very much to the Healthineers. And we will have a deep dive with colleagues of you in 1 month. And also next week, another deep dive. And so stay tuned, follow. And that's it. Thank you very much. It was a pleasure having you. Thank for your insights. I think it's really rare to get these kind of insights for us, for people outside of Siemens Healthineers, outside of the bubble, outside of the industry. And it was really, really interesting and inspiring and motivational.
Thank you.
Thank you.
Thank you.
Cheers.